Good afternoon or evening and welcome. My name is Connor Duncan from Kensington Senior Living. Usually Susan Evans is here presenting, but she has a conflict and she'll be joining us towards the end for the Q&A. So I will get us started. At Kensington, we have 8 unique communities, 5 located in Virginia, Maryland, and New York, and we have 3 sister communities in California. We're truly privileged to support care partners and professionals from coast to coast. And at our communities, we promise to love and care for your family as we do our own. Everyone that's registered for today's event will receive a copy of the webinar. Please also utilize the Q&A function to submit questions for Dr. Ayati. Today is for you, so please use that opportunity to ask anything. Please join me in welcoming Dr. Ayati, a great friend of Kensington and our medical director at our community here in Northern California. We've had the pleasure of working with him for many years, and his knowledge always continues to impress us. So, Dr. Ayati, I'll have you join us and share with the audience a few words about yourself.
Thank you so much. I think you just need to let me to start my video. Here go.
Oh, sure.
Okay,
Hold on.
perfect. Now we
There
can
we
see
go.
it. Yeah,
Perfect.
thank you so much, Hannah. I appreciate it.
Thank
No,
you.
great to be back again. But thank you for coordinating and organizing this event as well. Um, this is the second series of the talk that we had. The last one we had it last month was related to diagnosis of the mild cognitive insufficiency, how to manage it. And today we're going to talk about continue the same conversation, but mainly focus on behavioral symptoms that is related to people with a cognitive impairment. That's going to be focused. Now, I'm a geriatrician. I'm board certified geriatrician, and I practice in Northern California. I also teach as adjunct faculty at Stanford University and teaching geriatric medicine, also general medicine. Been more than 15 years that I'm teaching this subject. Very important subject today as we're going through that because this is one of the area that I'd like to share with you, especially for people that they have loved one or they have even a professional, they have clients with neurodegenerative disease. I'm going to start sharing my slides and we'll go through the conversation that we can have some time to answer some questions here.
Perfect. All right.
Thank you
Susan will
so
be on
much.
for the Q&A. Thank you.
Thank you so much. I appreciate it.
Bye-bye.
Um, just a second. I'm going to share it here. Okay. Let me just a second. Perfect. Let me go here. Show perfect. Okay, good. I'm hoping that you all seeing my slide right now.
We
Yes, it
do.
looks
Thank you.
great.
Perfect. Thank you so much. I appreciate it. As we know, this conversation is about, as I said, it's not only about memory loss. In the last sessions, we talked about developing the memory loss. What is the difference between aging brain, which I'm going to have a little bit of introduction on that. But one of the most important thing that we don't pay attention, it's about dementia is not only about memory loss. And majority of people, they have um, um, behavioral symptoms. As you remember on the last talk, we talk about people with MCI, above the 60% of people to 90% of MCI. The initial presentation only can be anxiety, depression, can be behavioral symptoms. And then the memory loss going to start. That's why we're going to talk today about mainly about the behavioral symptoms related to dementia. This is one of the main reasons that people with dementia usually need a caregiver or they need to be placed in the memory care facilities to manage that. This is one of the most harder part of the dementia that is extremely frustrating for many people. About this topic, I don't have any conflict of interest about that. That I don't get paid by any pharmaceutical related to anything that I'm sharing today with you. Um, Or understanding about dementia in general, as we discussed, dementia, it's only about the short-term memory loss. This is our understanding. Everybody says dementia means short-term memory loss. If you forget what you have done last weekend, or what did you eat yesterday, or what you have done in the recent event, that means dementia. That is correct. But dementia is a really general term. It's a lot of things in the brain can actually have impairment, and that can be even many things, like not only about memory, but also the way we think, the way we are plan, the way we are organizing our life, or social abilities. One of the early sign of the dementia, and especially people with mild deficiencies, the withdrawal, isolation. They are less engaged in the conversation. There have been more talkative person in the past, but they're less. This is why the dementia is a very spectrum of many symptoms related to the brain, and not only about the short-term memory. It's as I said, a lot of the interference with the daily function. That's about a dementia. And I'm very sure that anybody in this again the webinar, if you have a loved one or you see have a client or someone that has dementia, there are other side of the dementia, the other flip. If you're flipping this coin, the other side, you can see this symptoms of depression, anxiety, psychosis, which it can be delusion and hallucination. I will talk about it a little bit. Sleep disturbances, delusion. They have sometimes very aggressive behavior, the physical or verbal wandering. They can be very hard to be controlled. They're very irritated, and or they have apathy, that they have no interest to do anything. That's exactly what we're going to talk about. Quickly, I want to say about what is dementia exactly. As we remember, in the normal brain situation, as we discussed last time, we have two sides of the brain, the gray section of the brain and the white section of the brain. The gray section of the brain, which is a 40% of our brain structure, is developed from the birth, from the fetal life, and then all the way go to like mid 20s, late 20s, that the gray section of the brain stop the construction part, which is so important. It's all the process and information is really going to go to the gray section. And the white section, which is a 60% of the weight of the brain, usually started from the mid 20s and then go all the way to middle age. And this is the job is the translating the sensory information from different part of the body. That's very important because technically our gray section stop developing at late 20s. If somebody says that what is the age that our brain start to be retired, we talk about it many times. You hear from me, it's actually late 20s, early 30s is the time the brain start to be retired. It means that after age of 30, we are not adding new rooms or second floor or third floor to our house, which is our brain, but we just do remodeling. Anything happen after age of 30, we are just continue the remodeling. And this is the way our brain function. Like, for example, you are changing the cabinet, you're changing the tiles in the bathroom, or just changing the painting of colors. That's very important to understand because that can help you to understand your brain function. And that can help you about understanding what happened to the brain as the people get dementia as well. As you know, in the different side of the brain, we have different structure. We have a frontal lobe, we have a temporal lobe, parietal lobe, occiput, and cerebellum. As you know, the red section, as you see in this slide, is a frontal lobe, which is mainly thinking, memory, and the behavioral movement is actually go there. This is the area that is the last area of the brain that we develop, and this is the first area of the brain that is actually we lose it, either through the aging or through the dementia. We talked about it in the last session, and this is exactly what is so important. Temporal lobe is important because our short-term memory and our feeling and behavior is actually located. That's why these two lobe, which is frontal and temporal lobe, and the front part of your skull and your brain, the very, very important part of your brain, because these two lobe is actually are the lobes that getting affected by neurodegenerative disease slash dementia. And as you see here, that's why, for example, frontal lobes is kind of like a braking system of your brain, help you to stop from the abnormal behavior, and help you to control yourself. Impulse control, they're all going to go to that area. And as you see, the feeling of depression, anxiety are located in the temporal lobe. The other part of the brain, as we know, it's the parietal lobe, which is language. Speech is getting involved there. Occipital, which is a green color, more mainly vision. And we have the kind of like a brownish color cerebellum, which is the balance and coordination is affecting there. The people with dopamine diseases like Parkinson or people with the Lewy body disease, they actually have a more problem with that. The people with Alzheimer's dementia also later, this part of the brain is going to get affected. That's why the gait and balance is going to be much more impaired, and they are very risk of falls. And the purple side, which is a brain stem, it's the area that is not going to be affected by dementia or anything else till last seconds of life. When that section is going to stop, we're going to die because our heart is going to stop, our respiratory is going to stop, and we are going to die. That's going to give you an idea about how the brain is structured because it's important when we talk about dementia. And as you remember last time, we said in the hippocampal area, which is exactly located on temporal lobe, as you remember on the last slide, the yellowish color, the center that is responsible for short-term memory and learning. Like anything you guys are learning today in this presentation, it goes to that part of the brain. And it's so important because when that's going to be injured or get affected by a disease, especially for like a disease like Alzheimer's disease, that's part which is hippocampal area gets affected, and that can cause a problem with a memory, special short-term memory, and that's why, for example, ability to remember direction, location, orientation. Um, as a people that are actually living in, like for example, independent living in the facility, and you see sometimes they have a hard time to get to their apartment. They're getting confused, or sometimes they go to the same street that they're going, and they kind of say, "Where I am." These are the more orientation part, which is part of the short-term memory affecting that. What happened with age, which is not necessarily dementia, as we discussed, the brain start to shrink. And the brain size is after age of 65, it's getting significantly lower. Technically, after age of 30, we have the atrophy or shrinking started, as I said, from the time when our brain start to retire, which is age of late 20s or early 30s. And also the blood flow start to decrease 5 to 20%, especially for the white section of the brain. That's very important because, for example, when you talk about blood circulation, they can tell you that people with high blood pressure or diabetes or any cardiovascular disease, they have a higher chance to have more drop in their blood flow toward the brain. This very, very important thing. People, they have a clot in their arteries that goes to the brain. That is always affecting other medical condition like atrial fibrillation, many other things that affecting blood circulation inside the brain. They can make the brain to shrink more. And that's why the cognitive impairment is going to be much more. And what happened with aging that because two lobes of the frontal and temporal lobe, as you remember, the red and the orange yellowish color in that slide, they are getting more affected by just the normal aging. Well, of course, somebody with dementia is going to get worse. Why is it like that? And again, this is one of the biggest questions is that why after a certain age we are going to lose more? This is actually not going to happen in the certain age. We are continuously in the process we call apoptosis. Apoptosis means that we are in the dying process all the time, or cells always programmed to die in a certain time. And but we have a factory at the same time we can produce it again. There's a lot of biochemical things happen that we actually have the dead cell. Like for example, if you have a kid, small kid, they lose like a 20 to 30 billions of neuron cells a day. That's every day. Like in 24 hours, we use 20 to 30 billions of neuron cells. But they have a good factory. They produce it again tomorrow, the same amount or even a more amount of that 20 to 30. And when we're getting older, average adult, we lose 50 to 70 billions of the cells each day because of this process. Now, if we are very lucky, tomorrow we can produce the same 50 to 70 billions that we lost today. But if our factory is going to produce tomorrow 20 to 30, then we're going to be short for 20 or 30 billions. And that's exactly the beginning of the problem. Because more you're going to lose, or more or less you're going to produce, then this demand and supply chain going to be affected. And this is why brains start to become shrinking and atrophy and smaller. And that's affecting our many, many factors that is related. And we discussed very in details last time when we had the presentation that what are the elements that can be affected by just the aging brain. And if what happened if the aging brain process is going to be faster in some way. And as you know, that neurons is like exactly like a tree, and that we see somebody comes and trimmed leaves and branches, and that's exactly the shrinkage process happen, and the spaces between neurons going to be decreased, and this is exactly what happened in people with this process. One of the first thing that we see when our factory produce less and our loss is more is something we call a slow processing speed. That's the main complaint. Many people, as they're getting older, always feeling I'm slower. That's not necessarily at the time when they turn 60 or 70 or 80 years old. Even from age of 40 and 50, when you compare yourself at age of 50 and when you looking yourself at the age of 40, you're exactly going to see you're much slower at the age of 50 compared to 40. When you turn to 60, you will see you're much slower than even 5 years ago. That's the called a slow processing speed. And then one of the main reasons for a slow processing speed, exactly as I said, that it's really affect your ability to perform cognitive domain or many other tasks, or even anything like, for example, we discussed it last time. You will see that your multitasking function is getting less and less as you're getting older. That can be even in the matter of the 5 years. You can see from age of like 55 to 60, you're much slower when you are 45 to 50. You can do multitask at the same time, but as you're getting older, multitasking is just makes you extremely anxious. And as you're getting older, like for example, if you are taking care of your bank account, at the same time somebody call you and somebody else call in your cell phone and somebody else call you at home, then you get overwhelmed. Your brain cannot handle that. You see a lot in older adult people. They can do one task at a time because of the processing speed and less multitasking. An executive function, which we know in the frontal lobe, it's a very important part, engagement of any activities that you want to do, independent and necessary things for managing your own medical illness, definitely decline after certain age, but after age of 70, significantly is going to going down. Many things for planning, organizing, working memory, attention and impulse control is actually located there. That's very important because for the topic that I'm going to talk today, it's important to know that. As you know, some part of the memory, it's going to be long-term memory that we have. Some memory is a declarative memory, and some of them is procedural memory. Procedural memory, you don't forget that. Even if it's worst case scenario, we get dementia, knowing how. Like, for example, if you get older at the age of 80 and you still have a good knees and hip and somebody give you a bicycle, even if you haven't bike for 40 years, 50 years, you're still able to do biking. Your brain knows how to do that. If you're playing an instrument like piano or guitar, and if you still have a good fingers to play, it just takes like a 5 minutes for you to get back to piano, start to play some of the melodies that you remember from old days. You're able to recognize the note and continue that. Um, Semantic memory on the declarative memory, more on general knowledge, like where is the where is the state of California? What kind of part of the United States is California is located, east or west? This is general knowledge that you know. And episodic memory is one of the first thing that you remember you forget as you're getting older, which like for example, remembering anniversary, birthday. That's a good excuse actually if anybody forgetting the anniversaries or birthday of their loved one or somebody, because you can say it's just my brain is getting older, and that's true actually scientifically. It's nothing actually wrong. There's no nobody can question you, but scientifically that's correct. Episodic memory, it's something that you forget first. It's so hard to remember that. No, when you talk about dementia, over 100 diseases can cause dementia. And the most famous type of dementia that we have, it's going to be Alzheimer dementia, vascular, Lewy body frontotemporal. But a mixed term is very common these days because a lot of this dementia are overlap. But these only five is the most, but over 100 disease can cause memory loss and cognitive impairment. The mixed dementia is overlap. Most of the time, people with Alzheimer and vascular, they're very, very overlap. They have vascular and Alzheimer at the same time. Many people, they have Lewy body and Alzheimer at the same time as well. That's why the mixed type dementia is a very famous story. This is the picture of the two famous person. The gentleman in this picture is Dr. Alzheimer. In 1916, if I believe, I don't think 1906, 1916, in the Frankfurt, Germany, the country of Germany, and he was a neuropathologist. And this lady was a late 50 years old, that has been admitted in the psych unit because she had hallucination. She was very delusional. She was having visual hallucination and she had memory loss at the same time. But Dr. Alzheimer was so suspected because um, she was diagnosed with schizophrenia, but for him, it was questioning about presentation of schizophrenia with that degree of memory loss. This is why he asked about autopsy of the brain of this lady after she passed away. And she found interesting an abnormal plaque inside the neurons that called amyloid plaque. And from 1916 till today, that disease called Alzheimer's disease. The presence of this plaque, which is disconnecting of the neurons from each other. Later, the scientists found tangles. A tau tangles another protein. This is a very important protein. Both amyloid and tau are the normal protein. It should be in the brain. But the problem is when they, like an amyloid, when they get the plaque, or tau, when they tangle, it's like a hose that it got tangled in the backyard and there's no water coming from it. That's the very main reason for the disease of Alzheimer. And unfortunately, the high concentration of this plaque and then tangle is going to happen exactly on the two lobes that we discussed, frontal lobe and temporal lobe, and a hippocampal area. That's why the short-term memory get affected. And then later, behavioral symptoms also getting affected as well. As this is just showing that how the tau, as you see in the red color, and amyloid in the blue color getting affected that. But the problem is actually in this picture, which is from the journal of, it's from Lancet Neurology. And it's very interesting about this one because in this, again, uh, picture is just showing that, I just wanted to bring it up here. Um, oh, let me get, okay. It's showing here that, let me get the laser point here. As you see here, the person in cognitively is normal, and here it has dementia. Here, this is mild cognitive insufficiency that we discussed last time. But very interesting about the amyloid, which is you see in the red color here, and you see the tau protein, which you see this color here. Even years and decades before they even start to have clinical disease stages, means that even before they're starting to have memory loss, they already developed the amyloid and also the tau protein, which is a very, very scary part of this situation. That's why it is important to understand if somebody diagnosed with Alzheimer's disease or MCI, I don't know, age of like 71 years old or 68 years old, the development of this abnormal protein happened 20 to 30 years before. Means the starting disease of Alzheimer in this person probably started at the age of 35 or 40. That person was not aware of that. And that's accumulating, that 20 years later, 30 years later, the person has started to have a memory loss. And that's really interesting things about that. As you know, the Alzheimer is a really growing disease at currently around 5 to 6 million. But this is the number that we think it is. The number is much higher because many people actually they have Alzheimer, but we don't have a good documentation in our system. But we think about this is definitely double, more than 6 million. I think probably 12 million at least we have Alzheimer. But that number will go up as the aging population is growing up. And this is the worldwide situation. When it comes to behavioral symptoms, as we are talking today, people with dementia, at least 97% of people with dementia, they have at least one symptoms of the behavioral symptoms during their course of the dementia, and at least depression is one of them. This is one of the major clinical burden on caregivers, nursing home staff, clinician, the major risk, as I said, the caregiver burnout is always about behavioral. Memory loss, it's easy, it's piece of cake. If just someone has a memory loss, one caregiver can handle that. All we need is supervision, make sure we give medication as not getting elopement and not getting out of the house. That's it. But when it comes to behavioral symptoms, that's going to be very, very hard. And that's loss of neurons is actually a major cause of that, as I discussed, the shrinking that we discussed, especially in that some area. And as we see some nerves, like for example, the one is responsible for cholinergic activity, one of the enzyme and neurotransmitter inside the brain, there are more involved in that. And for example, decrease in cholinergic and serotonergic, which is serotonin, which is another neurotransmitter, alteration in, like, for example, norepinephrine and many other things in the brain, it can cause a major causing of the many of the symptoms. You don't need to go there to that level, but the four important neurotransmitter of the dopamine, serotonin, cholinergic, and norepinephrine. And this is a principle of that. Dopamine increase, serotonin, cholinergic, and norepinephrine decrease. That can cause significant a problem with the memory and behavioral symptoms. I'm sorry, and that's what we are going to discuss about that. When we look at the Cohen-Mansfield agitation, as you see here, there are a lot of symptoms are here. Let me just make it a little bit bigger here. As you see, for example, pacing, inappropriate dress, spinning, meals, cursing, request for attention, repetitive sentence or questions, hitting, including self, kicking, screaming, biting, throwing things, pushing, grabbing onto people, intentional falling, complaining, being very negative, drinking and eating inappropriate substances, hurt self or others, like with the hot water, anything, handle things inappropriately, hiding things, hoarding things, general restlessness, making physical sexual advances, making verbal sexual advances, performing repetitive manners, and deterring things to destroying the property. These are the kind of like the symptoms that you can see in inventory when we look at the different type of the symptoms that people can have. Psychosis, as you know, is like a delusional things, which is mainly on the frontal area. We call mesotemporal and frontal area of the brain. Depression is actually degeneration that we see in some sort of the nuclei inside the brain that is responsible for serotonergic transmission. Serotonin is important neurotransmitter that helps with depression. Apathy, which is definitely what we see in the parahippocampal area, frontal area, parietal neocortex, hippocampal and basal area, that we see the apathy can happen, and agitation, which is hypofunction of serotonin and cholinergic system, relative hyperfunction of the dopaminergic, which means the dopamine is going to be increased, and that's resulting of the more agitation. When it comes to psychosis, we have delusion. Majority of people with dementia, they can be extremely paranoid. They're always feeling that somebody is stealing their stuff, the caregiver is stealing their stuff, or family members. Hallucinating, which is more visual, especially very common in Alzheimer and Lewy body. Lewy body is actually presenting first with the visual hallucination. And majority of people on the moderate stage of the disease started to psychosis. Psychosis is not at the MCI level. MCI level is more anxiety, more depression. But when they get to moderate stage, then the hallucination psychosis is going to start. And the moderate stage is the worst stage. As they're getting more to severe stage, most of the psychosis is going to be less, or at least even they don't have ability to articulate this psychosis. They just start to scream. They have a psychosis, they see something, but they cannot say what they're seeing, and they start to scream. They start to become so agitated. They're going to hitting everyone. They're going to throwing stuff because they're on a severe psychosis. And as I said, it can cause agitation. And there's a difference between the people with the schizophrenia and Alzheimer or dementia. In dementia overall, this hallucination is not complex. It's very simple. They're seeing something. They see a small people, a small kids, animals. In the schizophrenia, they or usually is a command hallucination. Like for example, they get order. They're talking to the person. They're telling them what they need to do, and they're following that direction. This is a difference between psychosis if somebody has the psychosis in like a schizophrenia and psychosis in the people with dementia. That's a difference between that. And as you see that, for example, incidence of hallucination and delusion in people with dementia, like years after that, and as you see that as it getting more advanced in the disease, the chance of psychosis is going to be much higher. And as we know, that definitely the cerebral cortex of the brains get very degenerated. We're going to lose a lot of neurons, as I explained at the beginning of presentation, and that's why the serotonin, which is an important neurotransmitter in a cortical and subcortical part, going to be less. And the very interesting things that you always remember, the people have more rapid decline in memory, higher chance that they're going to have a psychosis. And that's very important. Like in compare of people, they have a slow down pace of the memory loss. I see most of the time this level of delusion in the people, they have sudden loss of the memory. And definitely, easily we can see even when we do electroencephalogram of the brain, we look at the wave and we see that there is a cerebral dysfunction. There are many antipsychotic that we use in that the problem. Major things about this because we wanted to block their dopamine. Dopamine is going to go high. That's why we use the medication like risperidone, Seroquel, which a generic name is quetiapine, Abilify, or olanzapine. These are the medication that can help with this situation. But again, this medication can be extremely having side effects, especially cardiovascular. They can increase the weight. One of the problem with this medication is weight gain in all of them, metabolic syndrome because it's insulin sensitivity problem, and that's we can use that. Although it's a black label by some FDA, but definitely for people should be very low dose. And that's the people are using it. They really need to have some sort of the knowledge and experience of how to use that because they're very different and they can have different side effects. That's why it's so important to really look at it. Agitation, as we discussed, it's behavioral symptoms globally defined as agitation. Because when we call like the nurses on the floor, nursing was, oh, patient is agitated. The agitation can be anxiety, can be depression, can be many, but the general term is agitation. But it can be verbal, it can be physical, and majority of the reason for placement is always that say agitation. But that sometimes can be dynamic factor. It's not necessarily neurodegenerative. For example, if the person with dementia has a pain, infection, they can be stimulating too much, like too much noise. I always I'm very sensitive about the noise, especially in memory care. Very high volume music, loud conversation, lots of noise always make their agitation to get worse because they don't have the part of the brain to really understand, okay, well, this is, they can calm themselves down. They don't. A lot of time when we wanted to bring the excitement for them, we actually playing a loud music in memory care. This is the most wrong thing that we do for them because it's actually increased the level of the sundowning later of the day. And that's something that we less pay attention to that. That's a very dynamic factor. Many of them, they have a already buzzing and ringing in their ear. And when they have when we have a loud music, for hours they can have a massive vibration in their ear, and that can be presented as agitation later of the day. It can be wandering. They can have excessive walking behavior, which it can be part of the restlessness in these people. They can be physically very aggressive, which is one of the main reason the physician usually called to treat the people. The 15 to 20% of people with dementia can have violent behavior, and mainly is a neurochemical things. And more in men happen, more severe dementia. It's one of the major cause of caregiver depression, and really affect the sleep pattern as well. 20 to 60% of people with dementia can have a depression. That's very, very high, and is often by first symptoms of the Alzheimer's disease, as we discussed. People even with mild cognitive insufficiency, they can have what the depression. It's really unclear whether depression is early manifestation of Alzheimer or susceptibility through the another mechanism. But depression may result from the patient's recognition of severity of his or her cognitive impairment or neurotransmitter dysfunction. Sometimes they said in people with MCI, the reason for depression because the patient is still aware of their losing memory. That makes them depressed. But some people say, no, it's really not. It's just the chemical is changing inside the brain. I want to be a little bit faster because we can wrap up and answer the question as well. The sleep disturbance is one of the other parts of the problem, which they have a problem with the brain circadian rhythm. And I will tell you what does it mean. A brain circadian rhythm is mean night and day will be different. Day will be or night. Or night is going to be their day. I'm going to explain to you what does it mean. It can be completely neurochemical inside the brain. Of course, environmental can have effect and drug side effects can be. First of all, I just want to tell you about the physiology. Why do we need to sleep? That's a very important question. Why do people overall, people with dementia do not sleep well, and why people why do they sleep in the daytime and they awake at the nighttime, and what happened to our brain that if our brain doesn't sleep? Let me answer this question first. That what happened to our brain if our brain doesn't sleep? This guy is the Randy Gardner. He is born in 1947. He actually went through the study that by actually one of the Stanford researcher who passed away a couple of years ago, Dr. William Dement. And that was a very interesting study that he started to be awake for 11 days and 24 minutes. And they did all kind of like a lab test, blood test, the electroencephalogram, EKG of the heart to see what happened, not using any stimulants at all. And that study has been completed in 1964. What they notice is that at the second day of not sleeping, his eyes stopped focusing. He stopped identifying object with touch. He couldn't identify between the rough subjects or soft subjects at all with the touch. And day three, he becomes so moody and uncoordinated. His mood start to change. He start hallucinating. He start to have short-term memory loss. And then he start to become paranoia, which is delusion start. And he completely recovered very well. But that's going to be good things to understand. If we don't sleep, many of the behavioral symptoms that we see, including short-term memory loss, behavioral symptoms can be related to sleep disturbances as well, which we see in the Randy. One of the reasons for sleep, I will skip it to melatonin, which is a very, very important protein or enzyme inside of brain, which is technically responsible for the brain circadian rhythm. It's the brain master clock. Is the way that we're responding to the day and night and light. All of us, we have it. Animals have the same brain biologic clock. Plants they have it. Microbes they have it, and we also have it. How does it work? When we are sleeping, I want to show it here with the laser pointer. As you see here, this is the light, and light goes to our eyes, which is the or retina, and the light goes to brain. It get processed there, and it goes to the place that we see on the red side we call suprachiasmatic nucleus. From there, the brain understand the light is coming, start to process, send the signal to the place which is called the color of blue called pineal gland, and the job of the pineal gland is producing natural melatonin. Means technically light to the eye, go to suprachiasmatic nucleus, and then go to the producing melatonin. As you see here already in this picture, in people with dementia, many of these paths has been broken, like from retina to the suprachiasmatic nucleus, from here to pineal gland, because of abnormal protein, they're all broken. This is why it is important to understand that why the people with Alzheimer, they have a problem. But what does it mean with that? When you produce melatonin, we go to circadian brain rhythm. And circadian brain rhythm, as you see here, for example, at the 9 p.m., imagine that you live in California, the melatonin that for the lights that you get during the day, you have increase in melatonin, which is going to be start to releasing at like 9 p.m. And then it's so important because the melatonin is going to be telling the entire body that there's a time to sleep. Your bowel movement needs to be suppressed. If it doesn't suppress, you have to go to the bathroom all night. And also your urinations should be stopped. This is one of the major problems. The people have more problem with the sleep because of melatonin. They actually go more frequent to the bathroom. At 2 o'clock, you have the most deepest sleep if you're so lucky. Melatonin, I will show you in the picture, is actually is against of the body temperature. When the melatonin is going to be to the highest level, your body feels cold. That's why sometime in the beginning of the night, your body doesn't feel cold, but in the middle of the night, your body feels cold. You're looking for blanket in your bed. 6 o'clock, you wake up, you have the sharpest rise in your blood pressure right after you wake up. And then your melatonin is stopped at around 7:30. Imagine that you still live in California, which we have a sunrise. Your bowel movement is start right after your melatonin is stopped. This is why like 8, 9 o'clock in AM, most of the building has a traffic in the restroom. And then your testosterone is going to rise. You have the high alertness around 10 o'clock, 12 o'clock, noon. You have the best coordination in the afternoon, faster reaction time. Interesting, about 5 p.m., you have the maximum cardiovascular efficacy and muscle strength. And if your cardiovascular efficiency is going to be so high, and this is one of the best time you can do the exercise. And then your blood pressure rise up in the later evening, and you go to the circadian brain rhythm. This is our circadian brain rhythm. This is the way we live. Now, everybody has a different brain circadian rhythm. If you're able to understand your own brain circadian rhythm, that's really going to help with many of the questions that you have regarding sleep. As you see here, as I said, the pineal gland start to beginning the production of the melatonin. Melatonin is going to go to the top, which is like probably around like 2 o'clock to 3 o'clock, and then it start to go down on the 7 o'clock. That's the way it works. But in dementia patients, all this pattern of the connection between the brain for production of melatonin is all gone. They're all gone. There's nothing. That's why the people with the dementia, they don't have circadian brain rhythm. That's important to understand because that means that when there's a day outside is their nighttime. And when it's a nighttime is actually or daytime. This is why many people with dementia did not have ability to to sleep at nighttime because they are actually in a more the situations of uh, not able to wake up during the night during the daytime. They actually feel very sleepy during the daytime, and nighttime will be different. The other one is adenosine, which is adenosine is one of the other neurotransmitter which is called sleep pressure. And this is very important part. This is one of the major enzyme that it's as accumulating inside the brain, and it's one of the production of the muscles. And as you know, caffeine is one of the major a blocker of the adenosine. When you drink the coffee, you block the adenosine, and that helps. But that can answer this question: why exercise to make you sleep better? Because of the adenosine, you are when you do exercise, you produce more adenosine to your muscles that accumulate inside the brain, and that makes you to fall asleep better. But what happened during the sleep is actually the sleep is the time that our janitorial system, which we call glymphatic system, start to the cleaning of all the adenosine from our brain, all the junk and trashes inside the brain, which is technically from our spinal fluid. It goes to the brain, is circulating there, and is helping to clean it up, the stuff. And this is so important because exactly as you see in the picture, is all cleaning process happen during sleep. That is can explain to you if you don't have a good lymphatic system, and if you don't have a good sleep at night, then the next day you're so drowsy, you're so sleepy, you're so groggy, your memory is also going to be affected. When we look at this picture, which is our last slide, the irregular, we have a different pattern. As you see here, I don't want to go to that level, which is this is usually what we call the delayed sleep phase. Young adult, usually teenagers, they sleep much later because their melatonin going to produce later, and they sleep all the way to 12 p.m. As we're getting older, we feel sleepy earlier in the evening, and we wake up at 3 a.m. Normal sleep, I would call it normal sleep, 8 p.m. to like 8 a.m. But this is the pattern that you see here in this picture. I'm going to show it with laser point. This is mainly dementia patient. They sleep for 2 hours and they wake up for 3, 4 hours, and they sleep another 2 hours and they wake up again. This pattern is very common in these people, and this is exactly what we see in them. The key point is the psychological symptoms and behavioral abnormalities are very common in people with dementia. 30 to 90% of people with dementia, they can have some degree of these symptoms during the course. And someone that have no past medical history of any mental health problem, when they get this neurodegenerative disease, they can get one symptoms of the mental health problem. And the most important thing is that approaches is going to be very different from somebody with mental health disorder, and they need more expertise globally. Just wanted to thank you all for your time, and I'm happy to answer the questions. I believe that Susan also joined us as well, and I'm going to stop my sharing back again to the platform.
Thank you, Dr. Ayati. Thank you for being Kensington's medical director, and thank you for all the knowledge that you're sharing with everybody. It's just so informative and so valuable. There's been a couple comments that everybody would like a copy of the presentation, and I have explained that you will all receive a copy of the presentation, also a copy of the webinar. So thank you. A couple questions that have come in. One just came in. Is it true that intelligent people are more likely to get dementia, but they also do a better job of hiding it?
No, that's actually not the case at all. We don't have any relation. We haven't found any relationship. It's actually with intelligence or higher education level at the presence of dementia. Dementia is now is nothing to do with IQ and the level of education. Dementia is mainly related to possibly of the two or three major mechanism. It's a vascular, highly vascular, metabolic situation, and the possibility of inflammations or maybe immunologic relationship. And this is the three triangle that is a disease process. And that disease process can happen in anyone, no matter the how level of the IQ is. However, we're seeing people with higher level of education, they actually, because they have more reserve in their saving account, they're getting much later, or possibly the manifestation is going to be much later because they have a good reserve, they have a good saving in their account that they can use at the time when they're losing it faster. This is why actually in the people with higher education, we see that it does help with presenting, or the people have a higher IQ level, but mainly education, the people are more reading and they actually have later presentation, but it doesn't matter. of the presence of dementia, because we know the reason for dementia is more likely, as we discussed in the last presentation, very high likely vascular. I personally, as in the group of the physician, I'm not a scientist, but based on what I've seen in my patients, majority of people that I've been treating for dementia, they have had some sort of the vascular problem sometime in their life, either high blood pressure, hidden atrial fibrillation that they never diagnose, and sleep apnea. It's very, very important about sleep apnea. I can't tell you that how many people I've seen with the sleep apnea for decades when they had it in age of 30, 40, 50s, and they never know about that and never pay attention. Later, they got dementia and the heart disease. And the other part is the metabolic, which is insulin insensitivity, which is technically still is a vascular problem. But no, it's really not about the IQ and intelligence.
But better at masking it because of their reserves.
Yeah, reserve is much higher. Yes, it's always the people have a higher reserve. The manifestation is actually much easier because they have ability to compensate. This is what we call a scaffolding pattern. Means the brain, like a scaffold that you have in front of building, they have ability to make a scaffold and able to repair it because they have some reserve neurons in their saving account that they can use it.
I have heard that that's also true, not that we have time to get into this, but recovering from a stroke as well.
True. Yeah.
What about non-pharmaceutical treatments to treat some of the behaviors that we were talking about or the sleep that we were
Wonderful.
talking
Yeah,
about?
that's a great question. It's actually non-pharmacologic approach for the managing of the behavioral symptoms related to dementia overall and MCI and dementia. The major principle of the treating any of these symptoms is number one is non-pharmacological. The pharmacological only going to be indicated which when the level of the symptoms it's very high enough that first non-pharmacological fail and the second cause caregiver burden or the third is a possibility of hurting himself or herself by the patient or hurting others. That's the only indication when the pharmacological come to the picture. It's so important because a lot of people, the minute they see the anxiety and depression in people with dementia, we jump onto prescribing medication. That's not the approach. Always approach is going. No, when it comes to non-pharmacological, it's a really variety that have been studied. That can be from music therapy that has shown a great evidence actually. They're very popular in some countries like in Germany and Holland. They're doing a lot of music therapy for people with dementia. Physical activity, exercise, distraction, the similar activity, like for example, we see in memory, like in Kensington, they're doing in the activity time. These are so important. These are part of the treatment because the minute you're able to distract a person, you're able to distract from the causation of the anxiety that increase the cortisol, and that's going to be help. Massage therapy has been a study as well. Use of aroma, like a smell of aroma and massage therapy as well. It can be even holding the hands, even touch has been a study that how much it can actually help with managing of many symptoms. If we try this, for aroma, there have been studies shows about lemon balm, for example. There's one study I know about done in lemon balm, but there have been many other things that can calm the person. Sometimes even comes with animals and animals doll, like for example, that also showed that very effective as well. If you fail on this measurements and these protocols, then the pharmacological come next.
You know, it's interesting because my dad, who lived at Kensington Senior Living for over 7 years, they bring in live music every day. And there's really purpose behind that. It just brings the agitation down, it gets people up, and
That's
then
true.
they're hungrier for dinner and they sleep better. So thank you for that. The other thing is the positive approach to care with Teepa Snow is just worked so brilliantly and non-pharmacological, interventions. So
I agree. I
so
completely.
appreciate your support on that. Anyway, thank you, audience. On the West Coast, as we've alluded to, we're getting ready to start making dinner. Maybe it's a little early for that. But on the East Coast, please be safe and have an enjoyable early weekend. Tomorrow is Friday. Thank you again, Dr. Ayati.
Thank you so much. Great to be here.
Thanks.
Appreciate
Good to
it.
see you.
Bye.